Okay, so thank you for that generous introduction. Just again, I'm talking about lupus nephritis, and we'll go over some definitions and pathogenesis. Hopefully, you'll be able to understand the clinical manifestations and how to utilize diagnostic testing, and then go a little bit over management and treatment. Obviously, this is a lot, so I'll try to stay focused. I have no disclosures. So again, talking about definitions, pathophysiology, epidemiology, clinical presentation, diagnosis, especially when to do a kidney biopsy, management, and go over a little bit of the research we're doing in a trial that I'm involved in. So I wanted to start with the study that, this is a research talk. And so one of the studies that we're doing is an open label phase 1b study of this drug called felzartamab in lupus nephritis. And so a lot of the trials that I do are drug trials. So again, this is very vulnerable population. We need better treatments for these patients. And so it's always exciting when there's new possibilities and new drugs that we can help these patients with. So what's important in our studies is figuring out, who is the right patient that we can enroll in our study. And I think that that's the hardest part about our studies. So, what type of lupus nephritis should our patient have? They have to have a diagnosis of lupus and have certain criteria that I'll go over. When was the biopsy done? There's usually a specific time frame of that. What is their kidney function and what does it have to be enrolled in the study? What are the other details clinically? Like how much protein do they have to have? And what are the drugs that they can and cannot be on? And what doses when they're in a trial. So, I think for our trials, enrolling can be the most difficult part. And again, understanding who is the right patient to be in the study. So let me talk about lupus nephritis specifically. So I'm going to talk about the kidney, but I think we have to understand what is lupus nephritis. Lupus is a systemic disease that affects many different organs, and one of them being the kidney. A patient might see a primary care doctor, have random symptoms that have concerning signs of lupus, such as fever or headaches or even just fatigue, very mild symptoms. And when they ask more questions, they might hear about other symptoms and lupus may be a concern. And so primary care doctor may order an initial ANA test, a serologic marker for lupus. And if that's positive, then they get sent to a rheumatologist that I would say is the gatekeeper of the disease. They can treat many things, but if they have a specific heart abnormality, they might see cardiology, or a specific lung abnormality, they might see pulmonary, or if they have a hematologic abnormality with a worsening anemia or thrombocytopenia or low platelets, they might go see hematology, and they deal with all the muscle and joint issues. And then if they have kidney issues, which they should be screening for in lupus patients, then they'll come see me and get referred to me. The top right picture is a specific, it's called a malar rash. So it looks like a butterfly. That's a sign of lupus that sometimes we see. And if any of you have ever watched House, there's always this running joke that he diagnosed very complicated diseases and lupus always came up, but I don't think there was ever an episode where it was actually lupus. He picked kind of these other rare diseases. So in general, how do we diagnose lupus? There have been multiple different definitions. There was one in 1997 by the American Association of Rheumatology, and then there was one 10 years later in 2012, and then this one was in 2019 by a European group, and also the American College of Rheumatology. And they wanted to kind of add some of the other findings that we have in lupus. And so it's this nice scoring system, which makes it easy for some people to help diagnose. Because again, if they just come in with fatigue and a positive ANA, there's lots of other diseases that can correlate with that. And so for lupus, kind of understanding what the specific issues are So again, they can have low platelets, they can have a low white count, they can have inflammation of their lungs, they can have certain rashes. There's certain antibodies and serologies that can be positive. So anticardiolipin and lupus anticoagulant and complements can be low, or can be positive, and then complements can be low. So these are all, somebody has to understand what lupus is to order all these different labs and evaluate what the situation is for the patient. So for me and the kidney, what we worry about is lupus nephritis mainly. There's a couple other rare renal complications, but in the interest of time, I'll just talk about lupus nephritis specifically. It's usually what we're evaluating in our trials. So it's caused by a deposition of immune complexes in the glomerulus, mesangial endocapillary, in the vasculature, and mainly the immune complexes can be ANA, anti-double-stranded DNA, complement these inflammatory cells. So for those of you that maybe don't remember back to, our biology classes, basically we all have two kidneys. We only need one, but we all have two kidneys. Each kidney has like 500,000 glomeruli units, or these nephron units. And each of these nephron units have these like small balls of these capillaries that we see here. And the blood is filtered through these capillaries. We have the cortex and the medulla. All these nephrons, or these main glomeruli, are in the renal cortex. And basically, you'll have the passage of these small molecules into the urinary space, and we hope that they're able to keep the protein in their capillary loops. But if there's damage or if there's a problem, then we're going to see this leakage of protein, and we'll see these deposition of these immune complexes. So again, the glomerulus, looking at a larger scale, this is the nephron. Within each nephron, there's these glomeruli, which again are these network of capillaries. They're surrounded by Bowman's capsule. And then the capillaries filter blood and go back to the proximal tubule. And when we do a kidney biopsy and we look at the tissue, the main thing we're looking at is these glomeruli and the part of the glomeruli. So again, there are capillaries that are lined by endothelial cells. So lupus can affect the endothelial cells. The capillaries are held by these cells called the mesangium. Lupus can affect the mesangium. And then the outer surface of the capillary is affected by podocytes. So there's certain diseases that affect that. And the podocytes are lined with folds of cytoplasm called the foot processes. And there's other diseases like minimal change in FSGS that can affect the foot processes. So in each disease, when we do a kidney biopsy, we are able to, our renal pathologists are able to help us out by looking at what is affected within the glomerulus and evaluating which disease process it is based on the definitions. So again, this is another picture. Again, there's different staining. So there's light microscopy that will look like this. There's immunofluorescence I didn't show, which does staining of certain serologic markers. And then there's electron microscopy that again show the glomerular basement membrane, show the foot processes, and again help us diagnose this a little bit more. So again, endothelial cells, mesangial cells, podocytes, glomerular basement membrane, looking at all these different factors. That's what the pathologists do. So in general, when I was talking about those definitions in the study that I had, one of the things that we do evaluate and focus on is kidney function. So all our patients with lupus that affect the kidney, our whole goal of these patients is to keep their kidney function stable. If they have damage in their kidney from the lupus nephritis and we don't treat it over time, it will affect their kidney function. And if their kidney function gets worse, they can end up on dialysis or a transplant, and that's what we're trying to avoid. And this is what we're trying to evaluate. So in general, to evaluate kidney function, we look at the glomerular filtration rate, which is the sum of filtration of all those nephrons that I was talking about. Normal is about 100 to 130 mils per minute. And the way that we evaluate this, so the only way to directly evaluate this is by inulin, and that can't really be measured that well. So we actually calculate an estimated GFR using equations that I could do a whole nother lecture on with creatinine. There's also a molecule called cystatin C. So again, creatinine is made in the muscle and mostly filtered in the kidney. And so it's the next best thing to inulin to evaluate kidney function. And so creatinine is a blood test that we can check, and then we do different equations, and then we come up with this estimated GFR, which tells us, basically the percentage of kidney function. So if I have a patient, who has a creatinine of 1.4, their estimated GFR might come out to 54 mils per minute, and that almost tells me a percentage of where they're at. And so again, for all my patients with kidney disease, I want to check a creatinine level, and I want to check an estimated GFR. The cystatin C that I brought up is a protein. So creatinine, again, is made in the muscle. So if you think about it, if you have a patient that's very sick or has cancer and has lost muscle mass, that creatinine might not be that accurate. Or you have a patient that's a football player that's taking in 200 grams of protein and they're just bulking up their muscle mass. Again, their creatinine might not be as accurate. So cystatin C came along in the last 5 years and is another way to evaluate kidney function, not accounting for muscle mass. So if I get any of those situations where those patients come in and I want a little bit of a better evaluation, I might check a cystatin C with GFR. And so it's important to understand in your study how they're evaluating GFR and creatinine, and do we need a cystatin C to be checked? So again, our patients with lupus nephritis, which I'll talk about the clinical manifestations, are mainly asymptomatic, actually. So when a rheumatologist is evaluating a lupus patient, every 3 to 6 months, they should check their urine to make sure that they don't have kidney disease. When we do a urinalysis, it'll tell us what the color is. It'll talk about the specific gravity and all different things. The thing about lupus that we want to check out is, do they have blood in the urine and do they have protein in the urine? So we might see blood, which blood is more myoglobin or hemoglobin. So somebody that maybe has rhabdo, it'll be positive. What I'm mainly looking at is the RBCs, the red blood cells. And if you have more than 5 per high power field, then that is abnormal. And these red blood cells, that when we look at it under a microscope, it'll be these dysmorphic RBCs, which almost look like Mickey Mouse ears. And if you have a bunch of them clumped together, you can end up having red blood cell casts if they're very sick. The other thing that we look at is how much protein is in the urine. So a dipstick will tell us that there's, 1 plus, 2 plus, 3 plus. That's very vague. It's hard in a trial to quantify that. And so we want to quantify it better than having 1 plus, 2 plus, 3 plus. Oops. So we can check, if you just check a urine protein at one point in time, based on their concentration, what they ate, different things like that can affect that, and it won't be that accurate. So we do a urine protein to creatinine ratio to have more accuracy in and evaluating what the protein level is over a 24 time period. But the most accurate is to do a 24-hour urine collection. And a lot of our studies will ask patients to do that, which can be hard if patients are living far. They have to come do this 24-hour urine, turn it in, and then come back for screening. So, but anyways, that's the most accurate. A lot of studies will require us to do that initially, at least. Maybe sometimes during the study, but after that, you can usually do a urine protein and creatinine ratio. Again, I find when I try to make my patients do 24-hour urine collections, it's very hard. They have to keep the urine in the fridge. They have to be at home to collect it for 24 hours. Sometimes they'll forget maybe, and they'll be like, well, I'm not doing this again. And then it could be a little bit inaccurate. So we understand that. And a lot of times we'll check both, but a lot of times it's the easiest for the patient to check the urine protein to creatinine ratio. So that's what we'll do the most. Feel free. This is, again, can be very informal. If you have any questions, again, please stop me. I'm happy to answer any questions even in the middle, but we should have some questions at the end too. So again, in kidney disease and evaluating glomerular disease, which is what I deal with, which can be this rare kidney disease population, but there's multiple diseases that I take care of. It could be over 20. We have to evaluate how to categorize a patient. And so when we teach our residents and medical students how to evaluate these diseases, we say that these patients can either be in this nephritic pattern or this nephrotic pattern, which helps us differentiate, the patients that we're taking care of. So when you're in a nephritic picture, these patients will have blood in the urine, they'll have protein in the urine, but their proteinuria probably won't be that high. It'll be less than 2,000 milligrams. Usually these patients will have high blood pressure, and again, they can have these red blood cell casts. And these are the patients that can be sicker and develop kidney disease and have what we call acute kidney injury, where their creatinine is just rising before our eyes, and that's an emergency. Nephrotic patients, these are patients that don't have blood in the urine and they spill a lot of protein in their urine, over 3.5 grams of protein, so 3,500 milligrams. So we'll have patients that come in with 5,000 milligrams, 10,000 milligrams. And these patients do have symptoms where they have a lot of swelling, and their albumin levels can be really low. And so when we see urinary findings that are abnormal, seeing how much, evaluating and seeing who has blood and how much protein they have can help differentiate the patterns of disease, and that helps us come up with a better differential for these patients. So again, for lupus nephritis, what I had just talked about before, as far as the urinary findings with blood and protein, lupus nephritis patients are in a nephritic pattern. I'm not going to talk about this today, but there is this lupus entity called membranous nephropathy, or class 5 disease. Actually, I will talk about it for a little bit. And they fall in this nephrotic category. So when I get a lupus patient, looking at the urine and how much protein they have can help me differentiate between the types of lupus in the kidney. So I'm going to look at the nephritic disease pattern. And again, even in the nephritic diseases, if I have a patient that maybe wasn't diagnosed with lupus and shows up with urinary findings with blood and protein, I may evaluate it and do a kidney biopsy because I'm trying to differentiate what they have. And I might diagnose lupus nephritis first before they actually get diagnosed with lupus. So that's definitely a possibility of presentation. So these are possibilities of nephritic diseases. All these patients have blood and protein in the urine. Again, usually the protein's less than 2,000 milligrams. So how do I differentiate lupus from all these other diseases? So in general, let me just talk about lupus nephritis. So in patients with lupus, it occurs in about 50% of patients. So it's a pretty high rate. Greater than 50% of these patients with lupus will develop lupus nephritis within 10 years of their lupus diagnosis, and greater than 75% will over their lifetime. So it's important when you know you have a lupus patient to screen them pretty regularly for the urine, again, because they can be asymptomatic. 4 to 10% of lupus nephritis patients will develop end-stage renal disease. And again, we're hoping that with all our research that we can find better treatments and drop this percentage. And the incidence is higher in Blacks and Asians and Hispanics. So clinical presentation, again, as I've already said, they usually present and they're asymptomatic, which is why when we have known lupus patients, we will check urine, and sometimes randomly they have fatigue and somebody checks a urinalysis and then they get diagnosed with lupus based on their urinary findings. So again, they can have an abnormal urinalysis. They'll usually have blood in the urine, protein in the urine that's lower than 2,000 milligrams. And most of these abnormalities will occur in the first 6 months to 3 years of their lupus diagnosis. So again, initially when you have a lupus patient, it's important to diagnose. I didn't write this here, but there are a subset of patients that can be very, very sick. And when you check their creatinine levels, they're already rising. You might check it and it'll be, 1.3, which is higher than normal. Normal's 1. And then a week or two later, by the time they get to me, they're already 1.8 or 2. And that's a person that we might actually send to the hospital and do more urgent treatment and more urgent evaluation of diagnosis. So other things, the urine is very helpful, but when I see the urine and the blood is positive, is there other ways for me to differentiate lupus nephritis from these other diseases? So again, an ANA can be helpful. If it's positive, it might steer my differential towards lupus. Anti-double-stranded DNA is very specific for lupus nephritis and one that I order regularly. If I have a young patient, then I'm gonna order it. Again, a lot of these patients that I'm taking care of are young females, to be honest, in this population. They can have an elevated sedimentation rate, an ESR, an elevated CRP, and complement levels can be really helpful in lupus nephritis. So their C3 and or C4, different combinations can be low. And again, ordering these tests can be helpful in narrowing my differential. So let me talk about a patient that I saw. So I have this patient, she's 45. She has a history of lupus. She was diagnosed 3 years ago. She's been followed by her rheumatologist. She's put on a drug called hydroxychloroquine to treat her fatigue and joint pain. She gets put on steroid taper. And all this time, the rheumatologist is ordering blood tests and urine tests to follow her. And 3 years later, she has a creatinine level that's normal. But when we look at her urine, she has blood and she has protein in her urine. And the protein level is actually pretty high, over 3,000 milligrams. So, what do we do next? There's somebody that wants to say something, you can, but otherwise I'll keep going. So when I'm thinking about this person and I see blood and protein, again, I think some things that I'd want to do are non-invasive tests if I can. So knowing she had lupus, I probably think this is lupus, but I want to understand how she's doing. So we already did a creatinine level. It might be helpful to do an anti-double-stranded DNA, check a urinalysis, consider doing a 24-hour urine collection to confirm, and then checking all these other serologies that I was talking about. So doing an anti-double-stranded DNA, checking the complements can be really helpful. But the biggest thing about our diseases, or the biggest thing about the patients that come to see me, is who should get a kidney biopsy. So again, a kidney biopsy, it can be a very invasive procedure. So basically, we're sticking a needle in this patient's kidney. And again, the kidney is a very vascular organ. And so there's definitely a high possibility, a higher risk of bleeding. So I always tell people there's about a 1% chance that you would need a blood transfusion, about a 0.5% chance that we would have to go in and cauterize, some kind of vessel, and then a very, very low chance of, losing your kidney or hitting another organ or death. So the way that we do the kidney biopsy is us as nephrologists, we do kidney biopsies. Radiologists also do kidney biopsies, and actually more in the community, the radiologists are the one doing the kidney biopsy. At Stanford, we actually do the kidney biopsies on our own with a radiologist helping us. And we will have them come down to the radiology suite. We'll have them lay flat on their belly, and then we image their kidneys through their back. So we basically, put gel, use an ultrasound machine. So we're basically using sound waves to evaluate the kidney. And then sorry, I should have put a picture of the ultrasound, and we image the kidney using the ultrasound. We actually keep the patients awake during this procedure because when they breathe, the kidney moves pretty significantly. So we keep the patients awake. Sometimes I'll offer them like a benzodiazepine, like Ativan or something. And then basically I'll use lidocaine to numb up their back. And then I image their kidney and kind of numb up through the muscle all the way into the kidney, because the kidney can sometimes be 5 to 8 centimeters deep. And then hopefully after that, they won't feel anything. And then once we have a good picture of the kidney, we take this needle, almost like a gun apparatus, and when we click, it'll kind of snap a piece of the kidney about the size of the tip of a pencil, about a couple centimeters long. And there's 3 stainings that I talked about that we have to do: the light, the IF, and the electron microscopy. And so we'll take about 2 to 3 pieces, maybe more. We also have trials that we're doing at Stanford where if we have enough tissue, we'll actually ask the patient if we can use tissue for research. Sometimes we do that. And so again, we'll do 2 to 3. And then after we do the procedure, all the patient gets is a little Band-Aid in the back from where we had made that incision. And I do monitor the patients like at least 8 to 10 hours. Sometimes people will stay overnight. And what we'll do is we'll monitor their urine, make sure we don't see a lot of blood in their urine, and monitor their hemoglobin levels to make sure that it didn't drop and we have a concern of bleed. If the hemoglobin levels do drop, again, we can transfuse them, do imaging, make sure we don't see a bleed. But if you think about it, we're sticking a needle in an organ, and so it's going to clot. And so I always feel like you will see a little bit of a hematoma, but again, we're always hoping that we don't have this big bleed. So again, it isn't, an invasive big procedure. And so in any of our kidney diseases, the question is always, well, who should we biopsy? Again, we want to make sure that when we biopsy them, that we're answering the question of, will this help with diagnosis? Will this help with treatment? If you don't need those answers, obviously, then there's no reason to do the kidney biopsy. So in lupus patients, our guidelines actually just came out in 2024. They changed all the lupus guidelines or, made them more specific. One of the guidelines that they do recommend is if the proteinuria is over 500 milligrams, that's when we should do the kidney biopsy. So again, if I have a lupus patient that shows up, maybe their creatinine's up, or if they have blood or protein and the protein's 700 milligrams, their complements are low, their anti-double-stranded DNA, there is a very, very high likelihood that this patient has significant progressive lupus nephritis, and I should biopsy them to confirm and evaluate exactly what's happening, make sure that they're not they don't have some other kidney disease that I'm missing. So we do the kidney biopsy. And what's interesting is in a lot of the other diseases that I take care of, we'll biopsy mostly if they're over 1,000 milligrams is usually when people progress. But in my lupus patients, I do find that even at these low levels of proteinuria, they can have pretty significant disease. And so again, we want to catch it early, and we want to be screening these people early. And again, I'm going to biopsy this patient, even if they have only 550 milligrams of protein. It's important to get this patient a biopsy and really figure out what's going on. So I'm going to go over lupus classification. When we do these kidney biopsies, another doctor will get involved, our renal pathologists, who are awesome. All they do is read kidney biopsies all day long, and we need all, I think there's almost 5 of them or more, because there's multiple kidney biopsies coming in from all around these community nephrology and then also Stanford, and they get sent to our pathologists and they read them. So again, in lupus nephritis, we have different classes, which can be really helpful to understand these classes because there's only certain ones that we treat. So class 1, again, in the mesangium, there's very minimal findings. So again, this might be a person that has lupus, that really everything is normal. Their blood pressure is normal, their creatinine's normal, their urine's normal. Again, we usually don't biopsy these patients because they're usually normal, but there's definitely lupus patients that can have these early signs of lupus and they just have class 1 disease. Class 2 is where we see more of the mesangium affected. They might have some blood in their urine, but when we check the protein, maybe it's only like 200 milligrams. We might see a patient with high blood pressure in this situation. And again, this is still not a patient that we necessarily biopsy because when we've done studies, there's no need to treat a class 2, that many of them may not progress, like just by, treating their lupus or putting them on hydroxychloroquine or treating their blood pressure, all of this might get better. Class 3 and class 4 are a different situation, and it's evolved. I think when I was in fellowship, we weren't sure, like definitely we treat class 4, should we treat class 3 as well? And now it's definitely known, that we want to treat these patients early. We want to improve this disease. And so if we see class 3 or class 4, we want to treat them. And again, most of the patients that show up clinically with class 3 and class 4 will show up with blood in the urine, protein in the urine, and protein that is higher than 500 milligrams, and that they have high blood pressure possibly, and maybe even in this crescentic RPGN, this rapidly progressing. So again, a patient that shows up with this creatinine that's continuing to rise, and again, that's an emergency. The differentiation between class 3 and class 4 is that in class 4, more than 50% of the glomeruli are affected. So when, this is one glomeruli, when you look at a patch of glomeruli, I'll try to definitely put in more pictures next time. And again, if more than 50% of those glomeruli are affected, then that's a class 4. And then I wasn't going to talk about this other type, but there is this other type called membranous. And again, this type is the nephrotic type that I was talking about. And so they will have more than 3,000 milligrams of protein. So if you get, and they can have the class 3 and class 4 that I was talking about with a 5. And so when I get a patient and I look at their kind of clinical evaluation and I see that they have blood in the urine, but I also see that they have like 4,000 milligrams of protein, I'm thinking, maybe this patient probably has lupus nephritis, and they might also have this membranous type, again, because they have a lot of protein in the urine. So again, the kidney biopsy can be very helpful to help us understand exactly what's happening with our lupus patient in the kidney and help us guide treatments better and also help us evaluate prognosis. There is a class 6. Basically, there are some patients that unfortunately we've treated and they've relapsed, and when we do their biopsy, they still have protein in the urine, but when they do their biopsy, I just see advanced sclerosis. And again, I don't want to like subject that person to immunosuppression with side effects. So again, it's helpful when a patient that you've been managing for a while still has protein and, they're young, you want to do everything you can, but when you biopsy them and they see sclerosis, that's just the end. And again, you might want to do, you want to do dialysis planning, unfortunately, at that time. So again, these are all the different types of classes. Usually, hopefully, when I'm biopsying a patient, it'll be, the patient that has class 3 or class 4 or class 5. So again, you can have a class 3 plus 5 or a class 4 plus 5 as well. And in general, our pathologists have a way of evaluating these patients as far as their biopsy goes, which is really helpful for me to understand what's happening in my lupus patient. So again, the definitions have been changing, and in 2018, basically they made the diagnosis of lupus nephritis through biopsy more specific. So before, they were reporting like endocapillary hypercellularity, but it was very vague. They just said, oh, there's this endocapillary inflammation, but now they kind of report out all these different specifics. And actually before, they didn't even really report out on what was happening chronically. Were there crescents? Was there fibrosis or atrophy, which is chronic damage? And so now there'll be a scoring system of acuity, 0 out of 24. There'll be a scoring system out of chronicity, 0 out of 12. And so I can look at a patient and it's more helpful. I can see, oh, okay, they have this much activity, this much chronicity. I can compare biopsies. Some of my patients, unfortunately, will relapse during their time. And so it's really helpful for me to compare and say, okay, last time they had this much activity, before they had 0 chronicity. Unfortunately, now they have, a score of 3 or 5 on chronicity, and that can be really helpful. And just remembering that other histologic factors are not included. So again, there's these other disease entities in lupus for the kidney, like collapsing lupus glomerulopathy or vascular lesions or thrombotic, what we call a thrombotic microangiopathy. So these are other things that they'll report out that we didn't include in the score. So again, in this new definition in 2018, now we have more specifics with mesangial hypercellularity, specifically endocapillary hypercellularity. So again, as you can see, this one has more of these cells that are there. Crescents, like differentiating different crescents. So this is a cellular crescent, a fibrocellular crescent. Again, you don't have to know all these specifics, just trying to show you like how the definitions have evolved. So does proteinuria help determine the histologic findings? And there's been a couple of studies. So again, this notion of having 500 milligrams of protein, where does that come from? So there is this, I could talk about all the trials with lupus, but there is this trial, this Euro lupus data with all these patients, and they found that the patients that progressed the most were the patients that had more proteinuria, more specifically over 700 milligrams of proteinuria. And so a lot of the trials will use that 500 milligram cutoff, but this trial, Chadid et al. From Hopkins in 2020, basically retrospectively looked at the pathology of 87 patients that had less than a gram of proteinuria. I think the average was about like around 650 milligrams. And so the patients that didn't have hematuria, didn't have acute kidney injury, just had proteinuria was about 52 patients. And basically 52 of those 87 patients, that was about 60% of the patients. And then those that did have the isolated low-level proteinuria, that was lower than 650 milligrams. Again, 50% of those had class 3 or class 4. So again, all we have is proteinuria. It'd be great if we had other markers, but just showing that, again, in our lupus patients, it's important to biopsy them early. This study looked at 222 patients, DeRosa in 2020. And again, 80% of those did have proteinuria greater than 0.5, but they looked at those 46 patients that did have less than 0.5 of proteinuria, and 84.8 of them did have class 3 or class 4. And when the proteinuria was over 0.5, there was a 97.7% chance that they had disease. So again, we want to biopsy early with low-grade proteinuria. And if we're not going to biopsy them, let's say they have 300, 400 milligrams, that's a patient that you just really want to follow more closely. Make sure that I make follow-up with them, make sure that they're doing labs for these patients. So lupus flares, basically in this disease, our whole goal of treating this patient is to treat the patient and keep their disease quiescent and in remission. But unfortunately, I'm going to talk about treatments. The relapse rates are still can be high, and just showing in this study that every relapse that you get, there are higher rates of progression of the disease. The GFR can get worse and their mortality goes up. And so again, we need better treatments to keep the kidneys stable, keep this disease stable, and prevent them from relapsing. So again, just showing that the doubling of creatinine gets worse, the progression of end-stage renal gets worse in these diseases. Every flare that the patient's survival gets worse, every flare that you have. So I'm going to talk about management for the next 10 or 15 minutes. So again, when we talk about management in lupus nephritis, we have an induction phase, like the first 6 months of treatment. And then after that, we have a maintenance phase that has increased. It used to be around 18 months. Now we'll treat patients for even 2 to 3 years with maintenance, again, to keep their disease quiescent and stable. And so some definitions, in a study, you want to have clear definitions of the patients that you're involving and the definitions of who has a complete response. So in general, the definition of a complete response is reduction in proteinuria of less than 0.5, stabilization or improvement in the kidney function, and that is within 6 to 12 months, but we would like it to be within the first 3 months. There's primary efficacy renal response, again, the proteinuria being less than 0.7 and GFR that's not worse than 20%, and not needing any rescue therapy. Partial response is if you have reduction of proteinuria by at least 50%, that's less than 3,000 milligrams, and stabilization of kidney function, but not really proteinuria like going into remission, like lower than 0.5. So again, these definitions in a study can really help you, be more objective and have good outcomes that are definite and specific. So back to our case. So again, this was a case, I'm changing up the story, giving you more information about the story, but she was diagnosed 10 years ago. Then she got lupus 4 years ago. She got treated with this drug called cyclophosphamide, and then got put on maintenance therapy with Cellcept and for, I think, about 2 years, and then got weaned off the therapies. Maybe she was on it for a little bit longer, for 6 months ago. And then she gets repeat labs after getting weaned off. And again, she has blood and protein. We look at the complement levels, they're low. Her anti-double-stranded DNA is positive. So they restart Cellcept in her and send her, and then they repeat it and she still has proteinuria. And they, try to send her to see me and get referred, back to her nephrologist. So what's next? We do a kidney biopsy. And the biopsy shows an activity score. Again, hopefully you'll understand this a little bit better now. So an activity score of 6 out of 24 and a chronicity index of 3. So again, this is a flare for her. And unfortunately, within her flare, now she has chronic disease, but she still has activity. And her activity score might look a little better because, I didn't biopsy her as soon as she had the amount of proteinuria. It looks like she got treated a little bit, then got sent to me. And the interstitial fibrosis, tubular atrophy, that's what this counts, was 10%. So again, that's showing the chronicity. And she definitely had some crescent showing this active disease. So how do I treat this patient? Do I give her steroids? These are drugs that I'm going to come up with, that these are what we have to decide as a nephrologist, or what my fellows learn how to do. And also in studies, we have to understand which treatments they can be on and not be on. So again, the drug that she's already on, do we increase that? Do we switch her to cyclophosphamide that she got before? Do we put her on what's called target therapy with the CellCept, Pred, and tacrolimus? Do we add a drug called belimumab? Do we add a drug called voclosporin? Do we add a drug called rituximab? Or do we enroll her in a clinical trial? So again, all these are options that we have for our patients. And what is the best option? So let me try to spend 10 minutes and go over some of the studies. So in general, supportive care for any patient with kidney disease is to make sure that we control their blood pressure, number one. A lot of these kidney diseases will have high blood pressure. My patients will show up with a blood pressure of 140/90. I want to try to get that, below 130/80, maybe even closer to 120/70. And again, the main drug that we use, I think in our series, one of my colleagues will talk about chronic kidney disease, and we'll talk about some of these drugs more specifically, but we usually use a drug that directed towards the renin-angiotensin system, especially in patients that have proteinuria. That is a great drug to be on. So drugs like lisinopril or losartan, an ACE inhibitor, or an angiotensin receptor blocker. So anyway, all my patients will get started on that. And SGLT2 inhibitors with diabetes has come up, but has been used in non-diabetics. And I'm sure that my colleague who's talking about chronic kidney disease will bring that up. So again, these are all factors that we want to look at in my patients. And then, so in general, again, we want to have more kidney protection. So they'll be on an ACE inhibitor or an ARB to help the blood pressure. And then hydroxychloroquine, this malaria drug, is a good stabilizer. So in general, for lupus, when they have joint pain and things like that, they get started on it. But there are studies in kidney disease that it also helps maintain and stabilize. We always use steroids in all our kidney diseases, and we're always looking for better therapies to try to decrease the amount of steroids that they need, but we'll give them high-dose IV steroids for a couple days and then put them on an oral regimen of, prednisone 60 over time until we can figure out a good immunosuppression agent to kind of kick in and help us drop the steroid use. But now that we have more treatments, we can we're finding in studies that we can use lower steroid doses, which is really exciting because if you know anything about steroids, they can have a lot of side effects. They can affect patients a lot, even their mood and sleep. And so again, and have risk with bone health and infections. And so again, we really want to have better treatments than steroids. So again, in lupus, we understand that there's this inflammation that is happening, this cellular and humoral inflammation that's happening that can affect the T cells and the B cells. And so when we're looking at lupus therapies and lupus drugs that we've been evaluating, we try to find drugs that are directed towards the T cells and B cells. So this is where hydroxychloroquine, these antigen-presenting cells, this is where hydroxychloroquine plays a part. So you have antigen antibody issues that are happening. There is this drug called calcineurin inhibitors, this group of drugs that I'll talk about, and that blocks IL-2 and the T cell. And then there's these other drugs that I'll talk about, belimumab, that blocks this BLyS/BAMF, rituximab that blocks the B cells, and this MMF or CellCept that I brought up as a thioprin, again, that works on the B cells, and also Cytoxan that I had brought up. So again, even with these drugs that we're using now down the pipeline, there's probably 20 or 30 more drugs affecting different parts of the cell that we're really excited about treating, because again, many of the drugs that we have, the remission rates are still only 20, 30%, 40% for these patients. And so again, we need better drugs. I would love it if we could have remission rates in these diseases that are 60%, 70%. Excuse me. So again, I don't have time to go over all these studies and all these specifics, but if any of you want to go over the studies, they're written here. But in the 90s, initially for lupus nephritis, we were looking at steroids, and then we were looking at steroids with cyclophosphamide. And then we were looking at comparing cyclophosphamide to MMF or mycophenolate. These are induction drugs. And then later on the pipeline, we were looking for maintenance drugs. And we actually found that CellCept, which is what we use the most, or this MMF, can be used for induction treatment, and it could be used for MMF. So we can use a higher dose in induction treatment for MMF, and then later on we can lower the dose and use it for maintenance. But even with this exciting data on MMF, the remission rates were still very low. So again, down the pipeline, we're looking at other drugs. So cyclophosphamide was the drug that my patient had gotten treated with. This drug has been around for over 20 years. It can even be used in oncology as a chemo agent. It's an alkylating agent cross-linking DNA to RNA to inhibit protein synthesis and reduces the number of B cells and T cells. And the dosing can be IV or oral, but it definitely has a lot of side effects with infection. We want to stress contraceptive in our patients because it can cause teratogenicity. It can cause bladder toxicity, cystitis. There can be malignancies involved. So again, we try to use the lowest dose that we need. So again, this drug can work, but with all the side effects, do we have a better drug with a better side effect profile that again can have better remission rates? That's what we're looking for. So again, down the pipeline, that was initially studied, and then MMF or CellCept came about, about 10 years later, and we were really excited to have this new drug that depletes guanine nucleotides, so it decreases B and T cell proliferation and decreases antibody production. It is metabolized by the cytochrome 3A4A, so you want to look at certain interactions. And again, I'll usually start out with 500 milligrams twice a day, but if I'm doing induction treatment, I'll get them to three tablets twice a day for this drug. It does have a lot of GI side effects. People can get nausea and gastritis, and if you get that, we can switch them to a different formulation called Myfortic. But we have these young, like most of my patients are young females, like 20, 30-year-olds. And again, they have to take these 6 pills a day. And if they have nausea, they might not be as compliant. We want to monitor for that. It does have some other side effects like bone marrow side effects, birth defects. So again, you want to stress contraceptive. It can have infection and this PML, this kind of rare brain entity that can be there. So again, it's a good drug. It works, and we're excited about it, but we do still have more relapses. And again, the side effect profile is there. So it's going to talk about calcineurin inhibitors. So again, we have Cytoxan, we have CellCept, but again, the remission rates are not that high. So we need other drugs down the pipeline. So calcineurin inhibitors are a group of drugs that we actually use in kidney transplant patients. They inhibit this nuclear factor of activating T cells, and they stabilize the cytoskeleton of the podocytes. The main drugs that we've had around for a while are cyclosporin and tacrolimus that have 11 amino acids. But these cyclosporin and tacrolimus, you have to check a level to decide what dose the patient needs to be on. So I need to have my patients come to the lab initially every week or every 2 weeks to figure out what level they should be on. And then they have to check a level 12 hours after taking the dose. So they have to take their drug like 8 a.m., let's say, and 8 p.m. And then we have to check a level in the morning before they take that dose. And so voclosporin came along, which is a semi-synthetic structural analog of cyclosporin that has this methyl group added. And with voclosporin, you don't have to check a level, and it's more potent. So we were excited about it. So just in the interest of time, there was a study in 2015 that used tacrolimus with CellCept with steroids and compared it to cyclophosphamide. And we really actually found with multi-target therapy, a better effect than intravenous cyclophosphamide, which was really exciting. So some of it, this was a trial done in China. And so especially for my Asian patients, this was a drug combination that I was using. Again, it's a lot of pills. Like tacrolimus could be 2 to 3 twice a day, and then MMF can be 3 pills twice a day. But it was something that we were using we were this triple therapy that we were using. And then now we have voclosporin that just came out that got approved in the last couple of years. But again, it's more potent. It has less nephrotoxicity, and maybe even a faster elimination of the metabolites. Again, you don't need drug leveling. I think the downside of the drug is that you have to take 3 tablets twice a day. That's how the dosing is. It's like 23.7 milligrams. Again, when they did the studies, that's the dosing course that you had to be on. So this one's a pill. And again, they did a trial, this Aurora 1 trial. It was a multi-center, double-blind placebo trial in 142 hospitals with 27 different countries. This was published in 2001 in The Lancet. And again, all these patients got our drug, voclosporin, with MMF, or got MMF plus placebo. And again, we were really excited to see they looked at these patients over a year, and we were really excited to see that the complete remission rates, were 43.7%, which was probably the highest we've had in any combination of drug therapies that we have. But again, in me thinking about the overall picture, I'm like 43.7% is better than what we had before. But I really hope that, again, we can have other drugs down the pipeline that can get our percentages better. So again, the complete remission rates, they had a good spread of 179 patients in Voclo, 178 patients in placebo. And for a glomerular disease trial, this many patients is very powered, and that's very good. So again, 41% versus 23%. So again, really exciting, that we have another drug. And it's important to point out that the time to get the proteinuria better with voclosporin was 29 days. So within a month, you could get the proteinuria down, which is quicker than any of the other drugs. Again, in the placebo group, just using MMF, it was 63 days. So that was also really exciting. They also in the study used less steroid than we've ever used. So again, usually I'll use 60 milligrams of pred, and in this study, they, gave them a lower dose of IV and started with 20 milligrams in the patients that were less than 45 kilograms. So again, that's really exciting to have the option of using less steroids in a patient. And again, the data was strong, no matter your race, no matter the class, and also the amount of proteinuria. When they had higher levels of proteinuria, it still favored voclosporin, which is different than the other drug I'm going to bring up. So that was really exciting. And then they, again, the probability of reduction of proteinuria was much better in the voclosporin group. And so then they did a second trial. In the interest of time, I'll kind of rush through this, basically looking at patients that were on the drug and continuing them for 3 years to evaluate if they still did well. And again, within a month, they got the proteinuria down. And again, they sustained the lower amount of proteinuria in the voclosporin group, even at 3 years. And when they took them off, they only followed them for a month. I kind of wish we would, maybe a trial will come, or data will come out when they followed them longer. But even within a month, even when they took them off the Voclo after 3 years of treatment, we didn't see a quick jump up, which sometimes we do see in certain diseases. So that was really exciting. So again, after 3 years, and then we looked at the GFR data, which again is only 3 years. But again, even the GFR didn't change. So again, is there a lack of nephrotoxicity, which is really exciting? Again, I didn't talk about it, but calcineurin inhibitors are known to increase the creatinine a little bit and lower the GFR a little bit over time. But it was nice to see that within the 3 years of treating them, they didn't see that. So Benlysta is the other drug that has now recently got approved. This was in the New England Journal of Medicine. It was a study that came out, the BLISS trial in 2020. And again, Benlysta is an IgG lambda monoclonal antibody. So it blocks this BLISS that I had showed that picture before. It can be an IV formulation or sub-Q formulation. In the study that I'm going to show you, they use the IV formulation. And this drug has been around. Our rheumatologists have been using Benlysta for joint pain and things for so long. But we only got it FDA approved for lupus nephritis specifically recently in the last couple of years. And again, in this BLISS trial, they looked at MMF or Cytoxan, adding this belimumab Benlysta to it. It was a 2-year phase 3 double-blind study. This study was 107 sites in 21 countries with 448 patients. So again, very powered. And again, we were really excited to see that with belimumab, the complete remission rates were better. It was 30% in this trial, but that's still honestly better than MMF and Cytoxan alone. So exciting to have another drug that we can use. In the proteinuria category, though, when the patients had really, really high levels of proteinuria, the belimumab wasn't really favored. So again, when you have a patient that has a lot of proteinuria, maybe belimumab's not really the drug to go off of. So again, to summarize the two new drugs that we have, voclosporin has a better proteinuric effect, a faster effect. It's more potent. We don't have to check levels, but because it affects creatinine, usually you want to have a GFR that's higher, so it may not be that well tolerated in some of the patients that already have progression of disease. Benlysta has a little bit more of a delayed response. It actually does stabilize GFR pretty significantly, which is exciting. It also showed data that it reduced lupus nephritis flares, and it was better for proteinuria if it was lower amounts of proteinuria. So again, Benlysta may be something I would use. Maybe I could use voclosporin early, and then maybe later I could add Benlysta to kind of keep the disease stable and keep them from flaring. But again, it's a lot of drugs that our patients have to be on. So again, trying to figure out, what our patient needs. So in general, the KDIGO guidelines came out. I mean, I could give a whole nother lecture on treatment, but basically it used to be that we would mainly use the MMF and the cyclophosphamide that I talked about, but now they added that you could give voclosporin right off the bat or even belimumab right off the bat, with one of these other two drugs. Sorry, this is just a little bit of a bigger picture of me showing that. And again, for maintenance, we mainly use MMF, but we, can add the tacrolimus or cyclosporin or maybe even continue the voclosporin if we can get it paid for with insurance, obviously. And then, in the KDIGO guidelines, again, they put more lower dose scheme of steroids dosing. So depending on what drugs you use, maybe you could treat the patient with a lower initial dose of steroids. But still, in our lupus patients, everybody gets a steroid. I just think it's important to treat your patient as a whole. So again, I'm treating these young patients that are females. A lot of the patients that come to me, their whole goal in the first place was to get pregnant. And I'm kind of like, well, I want to get you to that goal, but you have a lot of protein in your urine right now, and that would be a risk for you to get pregnant. So we need to, evaluate you right now, figure out what's going on with the protein, treat you for maybe a year or two, then I'll help you get pregnant. And in the meantime, the drugs that I'm using, you need to be on contraceptive. And so we want to make sure that we're counseling them. And then just understanding that in pregnancy and lupus, it's very different. There are certain drugs we can use and certain drugs we can't use. And so some of them that we could use actually are the cyclosporin, the tacrolimus. They can be on steroids. They can be on a drug called azathioprine that I didn't bring up, but they cannot be on cyclophosphamide, Cellcept, which are the main drugs that we use, and methotrexate. And so again, you want to make sure before a lupus patient gets pregnant that, you really counsel them, we really understand their situation and do it in a way that's planned. And so again, I really enjoy having the relationship with my patients that are young females that I relate to, and just helping them with their goals in life. Again, treat the disease that they have, and if their goal is to get pregnant, helping them get pregnant safely. A thing that I want to remind everyone is that, we can order whatever drugs we want for our patients, but we don't know if they're actually taking it. And so a lot of the trials that you'll do, they'll ask you to bring in their medicine bottles, or, we need ways to make sure that they're taking it. And so, some of our trials, like for the voclosporin trial, you could check levels. You don't have to check levels, but, there might be levels that you can check to make sure. But when I'm treating my patients, I think the number one question when I see them back in clinic and maybe their levels aren't better, or their proteinuria is not better, is, are you actually taking your meds? And, a lot of times they'll be honest and they'll say, you know what, it's 6 pills. I always forget that nighttime dose. Sometimes I just fall asleep, and so again, really verifying their adherence to treatment is very, very important at the beginning. And so again, instead of just I could keep adding on medicines, but if they're not actually taking what they're supposed to be on, again, you want to be very specific and understand the patient that you're taking care of. So all my lupus patients are very different. They're in very different situations, and you want to understand them and get to know them really well. And maybe they might say pills are a problem, and then maybe I would pick Benlysta instead. That was an IV treatment. So again, kind of back to this case that I was talking about. So this 45-year-old female that had a history of lupus. that, got treated and unfortunately is in her second flare, her first flare. Now with the protein, we biopsied her, we understood that she has this activity score. So what would I do next? And actually this patient that's on steroids that got MMF for 3 months, and now still has proteinuria would actually honestly be the perfect patient for a trial. So it's somebody that, had been treated with the regular standard care of therapy, but still has a good amount of proteinuria. And that would be the perfect patient for the clinical trial. So I'm definitely going to bring up the clinical trials that we have. But what's hard for us now in lupus nephritis clinical trials is that we have 2 other drugs, the voclosporin that I was talking about and the Benlysta, that are FDA approved, that have been shown to improve this patient in this scenario. And those are drugs that I'm going to bring up to my patient as well. And some of the trials that we have are placebo trials. And so I think it's hard for a patient to say, well, I have this drug that's FDA approved for my disease. Shouldn't I just go with that? Why would I do a clinical trial? But if we don't have patients that do clinical trials, again, we're not going to be able to find a better drug that has good remission rates. So it's really hard. So, how do I talk to my patients? How do I enroll my patients in clinical trials? What is the right wording? And I want to do the right thing for my patients. So I do think shared decision making in this scenario is important. For me, I think I'm 50-50 on getting into a clinical trial or getting into doing voclosporin and belimumab. I actually would probably pick voclosporin for her. She still has a good amount of proteinuria, started out with 3,500 milligrams of proteinuria. So I probably would pick voclosporin if she was okay with taking the drug. But the clinical trial would be a great option as well for her to try out this new treatment that won't get approved for 4 or 5 years, but has promise, again, to really put her in remission. I mean, she already went into relapse once. And so again, I talked to them about how, we have these drugs. I have voclosporin that we can add, but the remission rates are still pretty low. And we have this trial that has this new exciting drug that has, data in other diseases. And we're really hoping to look for a cure one day. And, this could be a really great option too. I talk about how in clinical trials, we take care of them. I mean, they have our research coordinators' numbers, they have direct access to us. We follow them pretty closely. We see them every month. We're getting labs pretty often. We give them advice on what to do with their disease. And so I do think that they sometimes can get really great care being in a study and coming to see us more often. And so there's a lot of pluses to trials. And when patients have to get a placebo drug, the possibility, I can see how that can be a downside for the patient. But again, I really truly believe that we need better treatments for lupus. And I think when you're talking to a patient, you have to believe in the trial that you're the PI. If it's not a trial you believe in, you probably shouldn't be, wanting to be the site for that trial, but you really have to believe in the study that you're doing, to help promote it for your patients and enroll our patients. So anyway, I wish this patient was around when my trial right now is going on, because I think she would have been the perfect patient for the trial. But again, back to this trial that I'm doing right now, it's an open label phase 1b study of felzartamab. We're looking at the adverse side effects. Felzartamab's a new and up and coming drug that has been studied in transplant patients and in certain hematologic diseases. And so we're excited to try it in lupus. And again, the goal is to evaluate the safety and tolerability of this drug with standard of care in refractory lupus patients. So what's been really hard, we haven't enrolled anybody yet. And what's been really hard for this trial is, again, they have to be on a stable dose of lisinopril. So you want to make sure that you tell the patients that want to enroll in the trial not to change any of their doses of the meds that they're already on. They have to be on a stable dose of the CellCept. And what's been really hard is they cannot be on cyclophosphamide within 12 weeks, calcineurin inhibitor within 12 weeks. They cannot be on the Benlysta that I've been talking about. They cannot be on any of these rituximab or obinutuzumab. I didn't talk about it. And so what's hard is that when our nephrologists are seeing these patients in the community and they see that they're not doing well, they do a biopsy and they find out that they have lupus nephritis, they might start these drugs, and that takes away the option of the patient being in our trial. So it's been really difficult. It's like we need to again, just be really vigilant about looking at our patients that had just gotten a kidney biopsy and, again, trying to find them early to see if they're interested, in our trials. And that's what's been really difficult for our glomerular nephritis trials is enrolling patients. Again, because there are treatments around, they still maybe are not the best, and we need we need better drugs and we need more trials, but that's been the most difficult part about our trials is getting patients enrolled. And sometimes I do explain to them, like, we have the options of the Benlysta and voclosporin in the trial, and sometimes the patients will pick voclosporin over being in the trial, and that'll happen. And you just have to explain the situation, and the right patient will come along. So again, this felzartamab is a monoclonal anti-CD38 that depletes target cells. It's an IV formulation that you get every week for 5 weeks and then 4 doses monthly. And again, we want to look at adverse side effects, but also look at remission rates for these patients. We have a couple of other lupus trials. We have one with ravulizumab. We have one with this CAR T therapy. I could do a whole nother lecture, which is really exciting therapy that's coming about. So Dr. Lafayette, myself, and Dr. Kim are part of the Glomerular Disease Center. And then we have excellent research coordinators, Schick, Elizabeth, and Brittany. So thank you. And we have 10 or 15 minutes for questions. Feel free to email me also.
Thank you so much, Dr. Kamal. Really appreciate it. This has been very informative. Thank you so much for your time and expertise in presenting. So everyone, please unmute yourself or just put it in the chats for any questions you might have. I have been monitoring the chats. No question has come in.
Okay.
But definitely this was very informative, and probably you covered everything. So any questions they might have had has been answered in your slides. So I see one question come in. So IFN blockage is a treatment option in lupus nephritis?
I guess they're saying interferon blockage. So basically, I'm trying to think of what the drugs are that block. So interferon blockage, I believe the main drug that has come up as far as interferon blockage is a drug called anifrolumab. That actually there was a study done recently. I think it's the TULIP study that you can look up in lupus. So yeah, that is something that they're looking at. Anifrolumab is a drug that they've been using in lupus in general. I think our rheumatologists will use it, again, if they're having fatigue, or we did look at it in lupus. It did show a little bit of an effect for lupus and nephritis, but it wasn't as big of a response as some of these other drugs that we have. But it is an option, and it is out there, and can be used, but it's not one that I go to. But it's called anifrolumab.
Any other question?
After a lupus diagnosis, do you have any suggestions for changes in diet, especially regarding protein, potassium, and phosphorus? So this is actually like probably the #1 question that I get from my patients. Again, they're very young, and a lot of them, they're like, I want to do everything I can to improve this on my own. And, unfortunately, we don't really have a specific diet to help with lupus. I do think as far as lupus on a whole, for lupus nephritis, lupus on a whole, some of the rheumatologists, will talk about acupuncture and some of these herbal remedies. As far as kidney disease goes, if somebody has kidney disease, which they'll talk about in the chronic disease lecture, there is data that patients that were taking really high protein diets, when you have kidney disease and your GFR is low, that wasn't a great thing, and that there was more progression. And so if you, again, have a lower GFR, that's 20% below 20%, we do recommend a lower protein diet, but that's not specifically for lupus nephritis or improving lupus nephritis. And again, our lupus nephritis patients patients, usually their kidney function is actually pretty normal. And so we only really see the problems with phosphorus being high, again, because your kidney can't get rid of it, or the potassium being really high, again, because your kidney can't exchange can't get rid of protein, the potassium. Those only come about when your GFR is much, much lower. And so again, because our lupus nephritis patients have normal kidney function, we usually don't see those abnormalities. So there really isn't a specific diet. I guess the one thing I will say is a lot of my lupus nephritis patients early on in their disease have high blood pressure. And so we do talk about more lifestyle modifications. When you have high blood pressure, you should have a low salt diet. I do recommend that they try to eat more home cooked meals, try not to eat out, and try not to eat like frozen packaged meals that has a lot of salt in it. And so those are recommendations that I will give so they don't have to be on as much blood pressure medicine. But yeah, I really wish there were more changes in diet that we could have to help lupus. Another question that came up, do you expect CD19 CAR T cell therapy in lupus nephritis that will lead to durable changes? How long might the benefit to last compared to monoclonal antibodies? And I appreciate the comment about a great talk. So we are really excited about CAR T therapy. Probably at our site, there were probably 3 or 4 different companies that had come to us asking to do a CAR T therapy trial. I'm not sure why there's so many, but we are really excited that this could be a cure. I mean, that's what we're looking for. And the data is really great. I mean, the patient does have to be admitted to get this infusion and this CAR T therapy. And, the trials are just starting for that. So again, the data in other diseases has been really great and really exciting. And I'm really, really hopeful for that. So I'm excited that we have one at Stanford going on. And we'll let you know. We're always hoping for that cure. A question came in about how challenging is it to diagnose lupus nephritis early on. And I discussed class 4 or class 5 or different stages of the disease, and that if you get to a kind of the later stages, there aren't as many treatment options. So what do you recommend to ensure early diagnosis and prevention for this condition? So yeah, that's a great question. I think for me, it's like I get them later, like after like all this has come up. And so I think we try to make sure that primary care doctors are pretty knowledgeable about these kidney diseases, and that our rheumatologists are usually pretty knowledgeable about these kidney diseases. And again, our rheumatologists have to be very vigilant about checking the urine more regularly. So checking the urine, every 3 months or every 6 months. And if they see some finding, checking it even sooner. So it's all about screening. And so most of our rheumatologists know that when they have lupus patients, that all the complications that they could have, and they're all ordering urine pretty regularly. And a lot of times when they have any findings, they get referred to me pretty early. And then when I get them, I know how to treat them. So I think it can be challenging to diagnose, but it's mostly about everybody understanding that this can happen and doing really, really good screening for our patients for lupus. And then any primary care doctor that really is concerned about lupus, that again, we check the urine pretty early.
Fantastic. Thank you so much. Any other question coming in? I don't see any questions. And of course, I mentioned this earlier. We are recording this session, and I will be sharing a copy of the slides with you as well as soon as I receive the final copy from Dr. Kamal. I will send out an email to all the participants with a copy of the slides, a link to the recording, and also a link to evaluation of the course. For those of you who is requesting continuing education units credit or BRN credit, please make sure you complete the evaluation and you list your name in there. I can actually put the link to evaluation in the chats as well. But yes, especially if you are requesting continuing education units credit, please make sure you complete the evaluation. So if there are no further questions coming in, we can give the rest of your time back to you and to Dr. Kamal especially. She has been generously giving us her time for this talk. Thank you so much. Really appreciate again Dr. Kamal and all of you for participating. If you do not have any questions, we can end it here. I will stop the recording as well.
Great.
Thank
Thank
you.